All right, let's continue where we left off quite a while ago. And to remind you, we just started on membranous nephropathy at our last conversation, where we talked a bit about pathogenesis and presentation, the associations, the secondary associations with membranous nephropathy. And then we were shifting into, or now we're shifting into diagnosis, prognosis, and treatment. So let's do that. So there is a bit of controversy about whether membranous nephropathy always requires a kidney biopsy or not in order to ultimately make the diagnosis. With the dawn of serology testing or serologic testing for some of the autoantibodies associated with membranous nephropathy, this has become an area of controversy. You, of course, know that PLA2 receptor antibody is the most common autoantibody associated with idiopathic membranous, and that captures about 75% of idiopathic membranous. So the presumption is the remaining 25% is another form of idiopathic membranous, but is associated with other autoantibodies. And there have been a variety that have been discovered over the last year, and the list continues to grow. The last years, and the list continues to grow. It is said, or when originally reported, the specificity of the PLA2 receptor antibody was, deemed like over, 95% specific. That number has been challenged over the years. I think it's firm to say it's at least 90% specific for the diagnosis. But the near 100% specificity has been challenged. And we, let me say as an aside, we have some patients in our clinic as well who have lupus membranous with a positive PLA2 receptor antibody. So it is something that truly is, in my experience, not a perfect test. Okay, so there has been a publication looking at the diagnostic value of phospholipase A2 receptor antibody positivity for making the diagnosis of membranous. This comes out of a case series from the Mayo Clinic, and the distillation of that study is, well, as long as you don't have diabetes, lupus, or other recognizable causes of proteinuria, if you have a PLA2 receptor antibody that's positive, it's pretty much equivalent to doing a kidney biopsy. So I'll leave that with you to chew on and to inform your particular practice. I'll share that, I've certainly treated some patients without membranous nephropathy, without a kidney biopsy for membranous nephropathy. When, for instance, I have a positive PLA2 receptor antibody and they have a fresh pulmonary embolus where I'm reluctant to stop anticoagulation. Okay, so that being said, there is an increase in sensitivity by doing a PLA2 receptor staining on kidney biopsy tissue. Okay, so that is said to be more sensitive for diagnosing membranous nephropathy than the serology, and there is a reason for that. Number one, before membranous nephropathy remits, it will often become serologically quiescent. Okay, so the serologies anticipate clinical disease. So some of these diagnoses of membranous in the setting of a negative PLA2 receptor antibody are membranous nephropathies that they're on their way to remitting. Okay, and so that again, PLA2 staining at the tissue level is deemed a more sensitive test. Now, the specificity might be challenged. Remember when I think we talked about this above, when we talked about pathogenesis, I think, but when you're staining for PLA2 receptor, you're not staining on the tissue, you're not staining for the antibody. you're staining for the presence of antigen. That's, a normal antigen that's expressed in podocytes. So you might ask yourself, well, how does that make sense? Everyone then, whether they have membranous nephropathy or not, should be PLA2 receptor positive. And the reason or the rational argument for why that is a test that is used is that think of membranous as being a state of overexpression of PLA2 receptor that is being targeted by an autoantibody, and then that is being shed into the subepithelial compartment. Okay, so this is, maybe think of it as an overexpression of PLA2 receptor antibody, or excuse me, PLA2 receptor, and that's what's resulting in some decay in specificity, right? If I have a positive PLA2 staining, maybe I'm staining normal representation of PLA2 on the PLA2 receptor on the podocyte. Okay, moving on. Renal path is classic for subepithelial or for basement membrane spikes and subepithelial deposits. The spikes arise from the uptake of stain in extensions of glomerular basement membrane between the subepithelial deposits. So this is a basement membrane reaction that results from this inflammatory insult, okay, and these arising from these subepithelial deposits. So when I am staining black, what I'm staining black is these interdigitations of basement membrane between deposits. So the area of no stain is where a deposit resides, and these extensions of spikes are these interdigitations of basement membrane that are extending between the spikes. Between the subepithelial deposits. There is these are typically IgG3 and C3 positive, and there is some subclass restriction. Classically, PLA2 receptor antibody membranous nephropathy is positive for IgG4 subtype. And then there are other autoantibodies that are associated with other subclasses. So in the past, subclassing the IgG was part of making a diagnosis of idiopathic membranous as opposed to secondary membranous. At times, we relied on IgG subclassing in order to do that. We don't do that so much anymore now that we have the autoantibody to measure. Okay, there is a historic classification system for categorizing the findings on electron microscopy. They are not terribly useful in terms of disease prognosis or treatment responsiveness, so I won't dwell on them too much. You can think of this as evolution from early to late membranous nephropathy, in which, on the late stage, I'm actually starting to reabsorb and clear some of these subepithelial deposits, leaving these moth-eaten appearances on electron microscopy. Okay, so I won't belabor the classification system since it again has little relevance to treatment decisions and prognosis. Okay, now when you sometimes are struggling to determine whether this is primary or secondary membranous nephropathy. Now, things that argue for a secondary membranous would certainly be if I have negative PLA2 receptor antibody staining. That is not sufficient because we have other antigenic targets like the thrombospondin antigen that is the next most common idiopathic membranous nephropathy, and you can even measure a circulating autoantibody to that antigenic target. There are multiple others, but so just having negative PLA2 receptor antibody staining is not sufficient to say, well, this is a secondary membranous, because again, there are other antigenic targets with autoantibodies that are present. If I have, other features of lupus membranous then of course I'm leaning that way. So classically full house staining, tubular reticular structures on electron microscopy, that would be arguing for this as as secondary membranous from lupus. When I have electron dense deposits that are extending beyond the subepithelial space, so these are your subepithelial deposits, if I have deposits that are in the mesangium, if I have a few deposits in the subendothelial space, that would also argue for a secondary membranous. When I have deposits in areas beyond the subepithelial space, most commonly these are mesangial deposits, okay? And then I mentioned the subclass restriction can sometimes be used to tilt the balance away from a primary membranous. But that is not reliable enough. As I mentioned, some of these other antigenic targets have representation of these other IgG subclasses, even though they're still idiopathic membranous. And so that, again, is becoming a less useful tool for making that determination between primary versus secondary. Prognosis is, in general, reasonably good. And the GFR decline with membranous nephropathy is slower than an FSGS patient with equivalent amounts of proteinuria. Danny and I encountered this concept in one of our patients in Monday Clinic. So again, think of membranous as being a relatively slow mover in general, meaning you have time to take it conservatively, okay? And so because there is a spontaneous remission rate that is quite significant, 40 to 50%, if you even observe out in these very long timelines, that argues as well for a more conservative approach when making decisions about treatment. I may have other markers of better prognosis that include female gender, a younger patient, certainly blood pressure being normotensive is also a general prognosticator that is favorable. And if I have low amounts of interstitial fibrosis, that would also be a generalizable attribute of renal prognosis. These would maybe tilt the balance again to more conservative approach. If I'm subnephrotic, the prognosis is very good, and those patients in general are not treated with immunosuppression. So if you achieve, 1.5, maybe even 2 grams of proteinuria with conservative measures, you don't pull out the immunosuppressive hammers in treating a membranous nephropathy. That is true also for FSGS as well. So this is a generalizable treatment principle that you can use when treating the idiopathic nephrotic syndromes. If I'm subnephrotic, your work is largely done. You don't have to pull out these hammers that have side effects, the immunosuppressive hammers. Okay. Now, again, spontaneous remission is reasonably common. If you see proteinuria falling in the first year, that would argue for that a greater likelihood for that spontaneous remission to occur. So on the converse, if you're seeing proteinuria getting worse in the first year, you should you should have more concern. There is also some prognostic value to the degree or the height of the titer of PLA2 receptor antibodies. In general, as I mentioned, PLA2 receptor antibodies become negative or decline before the clinical remission occurs. And the way you can argue for that conceptually is that these immune complexes exist on the subepithelial side, and so they will take some time. Even if I stop the production of further autoantibody, these will take time to resorb and normalize normal podocyte function. And so again, I may have autoantibody production that has stopped, but it may take even a year for me to resolve the proteinuria in a patient who has membranous nephropathy. Okay, so again, in general, the serologies anticipate disease course. On the flip side, someone who's in remission will typically manifest an increase or a newly positive PLA2 receptor antibody before they develop clinical disease relapse. So that other direction I should emphasize as well. That being said, let me share, our personal experience in the Parkland GN clinic. We have a couple, at least two, that come to mind, patients that have positive PLA2 receptor antibodies, but are in clinically remitted states. And there's one of them that's been positive for years. And she just makes us nervous. I stopped checking the antibody. I just said, stop checking this. If she becomes proteinuric, then we'll worry. Let's treat her the old-fashioned way, right? We didn't have serologies 10 years ago. We didn't manage patients by checking serologies. We just followed proteinuria. And so we're old school in the management of that patient. Okay?
How high is her titer?
Very high. Yeah, it's not subtly high. It's very high. Yeah. There's two platforms. There's this Mayo platform, and then there's these others that are not translatable. So one platform is measured in relative international units, and then the other is a 1 to 160 or 1 to 320 or the typical titer. And it's not clear exactly how, to use that information. Certainly, I would say at best it's semi-quantitative when you're looking at titers. Okay. All right. So when you have somebody who is in a complete or partial remission, notice this rate of ESRD that's rather, reassuring. Even observing up to 10 years, one would expect that there would be a very low rate of ESRD. Again, arguing for even if I have a partial remission, it doesn't make sense in many cases to pull out these hammers like corticosteroids, calcineurin inhibitors, cyclophosphamide, rituximab, because again, the renal prognosis is generally pretty good. Relapses do occur in roughly 30% of patients. Okay, let's go on then to the treatment options that you have. Again, the goal is to get them subnephrotic, ideally, in a complete remission. But again, if you get them subnephrotic, you've done a great service in terms of the patient's renal prognosis. Okay. So of course you're using optimal antiproteinuric interventions first, and then you're managing the volume overload, which also tends to improve proteinuria. When you resolve the volume expansion, that reduces glomerular hydrostatic pressure and proteinuria comes down. And so again, you would optimize antiproteinuric interventions before typically bringing out the immunosuppressive hammers, with a couple of exceptions. Okay, I'll highlight some of those exceptions. I think in the words that follow. If not, I'll just give you the side education. Okay, if I have a case of secondary membranous, this has been described with nonsteroidals. It's been described with penicillamine and Thiola. That was discussed yesterday. I would typically just withdraw the causal factors and watch for the remission to occur before pulling out immunosuppression. Many people, again, deserve a period of observation for this spontaneous remission that occurs in 40 to 50% of idiopathic membranous. We don't typically do that in a lupus membranous, right? If you have a secondary membranous like lupus and they're nephrotic, we generally treat them. Okay, we don't watch people who have secondary membranous from lupus for a period of spontaneous remission. Okay, but then again, let me just jump ahead. You have time, even with lupus membranous. Membranous is typically a slow mover. I personally do not use corticosteroids when I'm treating a lupus membranous. I just put them on their mycophenolate or their calcineurin inhibitor because in general, membranous, whether it be secondary or primary, is a slow mover. And you don't need to quench the inflammation or the autoantibody, quickly with aggressive corticosteroid use. Okay. indications that would push you to consider immunosuppression are if I have deteriorating GFR, right? That's what I'm trying to avoid when I'm either instituting conservative measures or immunosuppression. If I've already arrived at a state of declining GFR, you shouldn't fool around and say, oh, let's watch you for a period of spontaneous remission, because you're already reaching the endpoint you want to avoid. So if GFR is already deteriorating, if you have a lot of fibrosis on kidney biopsy, those would be arguments against, conservative monitoring for spontaneous remission. Okay, so I've detailed that. If I have somebody who has a consequence, a significant consequence of their nephrotic state, that's life-threatening, like a DVT or a pulmonary embolus, I wouldn't say, oh, let's just put you on your anticoagulation and watch for spontaneous remission. In those cases, it makes sense to start the patient on immunosuppression to treat the nephrotic state that's predisposing them to this thrombophilia. I would add here, we've had a patient who has severe dyslipidemia. I would also put that in, do you want to have somebody who even on a statin has an LDL of 200? I wouldn't do that. I wouldn't want somebody to sit with an LDL of 200. I should add that here. We've used that as a decision maker in some of our patients as well. So maybe put your own notes in your field guide about that as a reason to treat. And then this concept of persistent proteinuria is an old concept. It comes from older treatment algorithms arising from our the Toronto GN registry. So that was an institution and individual, Dan Catron, who was sort of a leader in the management of nephrotic syndrome, including FSGS and membranous nephropathy, who published based on an experience from this Toronto area group of nephrology practices. And in a model that he published, there's this concept of persistent proteinuria. He said that if you had proteinuria after instituting antiproteinuria interventions that exceeded 8 grams per day for 3 months, or greater than 4 grams per day for 6 to 9 months, then that would warrant instituting immunosuppression. So that is one older model that has been used. This has been challenged with subsequent publications, of which came out of France, that said, even when you have 10 grams of proteinuria for a long period of time, there's still a significant spontaneous remission rate. And as long as GFR is stable, that is preserved, it's reasonable to even wait in some of these patients who have well-controlled edema, well-controlled dyslipidemia, and preserved GFR for a spontaneous remission. Okay? When you decide to treat, you have a couple of options. Okay? I would put these all sort of equivalent in their availability or preference. Okay, I would explain to the patient the various side effects and the duration of treatments that are involved, and then through shared decision making, make a decision about treatment. That being said, I think there's plenty of practicing nephrologists who really rely on rituximab now because it's so easy. The side effect profile is generally, fairly favorable in comparison to these others. But rituximab is a real medicine. It is a real immunosuppressant, especially if you look at some of the ankylosing literature. You can see real infectious complications from rituximab. So, I think I'm a little bit less enthusiastic about, always going to rituximab for my go-to. And then there's often some economic barriers in our Parkland patient population. If they don't have PFA, that might make me tilt towards these other options. Okay? That's my best fair representation. I guess the point I want to make is that don't be one-dimensional and say rituximab. The other reason I'm not so jumped on that bandwagon is I have reservations about how the Mentor trial was done. I think I've said it multiple times. It was a trial that was done in a way that was designed to make rituximab look better from the start. Anyway, and that's the trial that catapulted rituximab to the forefront of treating membranous nephropathy. Okay, so you have your various options. Rituximab given twice over 2 weeks, and then whether to give it again is a art of medicine decision. In general, I do, and then I give it in sort of a tapering protocol, which we'll go over in ANCA vasculitis. There is no tapering protocol for membranous nephropathy or lupus, but I translate my use of rituximab. I kind of use the evidence-based tapering protocol in ANCA vasculitis, which we'll get to when we talk about ANCA vasculitis, and I'll hope you remember that when you're thinking back to your treatment of membranous nephropathy. Most people, for me, are going to warrant another course in 6 months, and then I start tapering at the year where I'm going down to 500 milligrams per dose, and then just one dose of 500 milligrams. We'll go over that in our ANCA vasculitis discussion. Okay. Calcineurin inhibitor. If you're staying true to the Mentor protocol, if you reach a complete remission after just these 2 doses, they didn't give another dose. Okay, that was the Mentor study. They did give another dose if you were only partially responsive in the Mentor protocol. Okay, so that's where this bullet point comes from. Calcineurin inhibitor, to me, you have to prepare your patient for at least 1.5, my bias is 2 years of therapy. I've said that before in our FSGS discussion. It's clear when treating nephrotic syndromes with calcineurin inhibitors that there's a high relapse rate when you're doing only 6 to 12 months of treatment with a calcineurin inhibitor. So for me, I'm telling my patient at the get-go, if we're going to do a calcineurin inhibitor, you got to know that this is a commitment to 2 years of therapy. Okay. And I don't use steroids. The published randomized controlled trial on the use of calcineurin inhibitors done by Dan Catran, Catran is the correct pronunciation, I believe, in membranous nephropathy, used a low dose of prednisone. I don't ever use prednisone in treating membranous nephropathy. I've already told you again, this is a slow mover. I just try my, anchor immunosuppressant. This prednisone to me is nothing but side effects. It doesn't really help you. Okay. And then I taper it slowly over 6 months. So once I get to that 1.5-year mark, that's when I start thinking about tapering. And then you got to taper pretty slowly. Otherwise, there's a real risk of relapse. Okay. The levels, just use your transplant levels when you're deciding on what level to achieve. Okay. The other older protocol that is evidence-based, even with longer-term follow-up data at 10 years, showing reduced rates of ESRD, is the modified Ponticelli protocol. You don't have that kind of long-term data with either rituximab or calcineurin inhibitor. You do with the modified Ponticelli protocol. What is Ponticelli's protocol? It's complicated, and if you're true to the protocol, you're giving methylprednisolone for 3 consecutive days at a dose of 1 gram, and then you're giving 0.5 milligram per kilogram of prednisone for the rest of that month. Okay, and then on month 2, you stop the prednisone cold turkey. There's no taper. You just stop it cold turkey. You start them on chlorambucil if you're doing the Ponticelli protocol. The modified Ponticelli protocol is using the other alkylating agent, cyclophosphamide. Okay, Ponticelli said, he originally did it with chlorambucil. Nephrologist says, I'm not going to prescribe chlorambucil. I'm scared of chlorambucil. And so Ponticelli said, oh, okay, let's do it with cyclophosphamide. And this is the modified Ponticelli protocol. By the way, this was also redone by a group in India, and I think that was published in JASN. And they had some reasonably, I think it was like 2 or 5 year data in follow-up. So It's been reproduced by an independent group that it's a working solution for membranous nephropathy. You give it as oral cyclophosphamide. This is not IV. 2 to 2.5 mgs per kg per day. That's month 2. Okay. And then you just keep doing that, alternating. So you do that for a total of 6 months, 3 cycles of that. Okay. Steroids, alkylating agent, steroids, alkylating agent, steroids, alkylating agent, and then you're done. So when I'm counseling my patient, that's the upside is this is only 6 months. The downsides are it's complicated and there's steroids involved. Okay. And then when I tell them about calcineurin inhibitors, no steroids involved, it's 2 years, 2-year commitment. And then the rituximab is you don't have to take a pill. Here's your infusions. I have to tell you about PML though. Okay, that has to be in the consent form. That's sometimes scary for patients. Okay. Non-responders, right? So the question is, well, do I switch? And you do. When you don't respond, you generally say, okay, well, nothing happened. We should start the other. We should try the other one. Okay.
The rituximab, because it's only Q2 weeks for 2 doses, though. Like if it's like month number 2, do you continue to wait it out, or are you going to just go and switch then?
Yeah, that's a good question. So it asks you to think about what is the mechanism of action of rituximab, and what would be the time course of response that you might expect. Remember, rituximab is anti-CD20, which is not on plasma cells, it's on B cells. And so you would anticipate a delay in response of 3 months. I should start seeing something at 3 to 4 months. I'm not looking for a response at 2 months. Okay. Partial response is generally the achievement of a 50% reduction, similar to what we discussed in FSGS and minimal change. It's generally a reduction in proteinuria of at least 50% and achievement of subnephrotic proteinuria. Okay, so I should say, even though I didn't put it here, there is a small study that suggests a better response to modified Ponticelli protocol when you have higher titers of PLA2 receptor antibody. Okay, the more the tighter, the better, or the more reliable modified Ponticelli's protocol is compared to rituximab. Okay, and then even though I didn't put it in the field guide, I will tell you that we do modified Ponticelli protocol. I don't bother with the solumedrol. It's just too complicated in our health system. And instead of giving half a mg per kg, I just give you a mg per kg of steroids for that month. Okay, instead of solumedrol plus a half mg per kg of steroids, again, just pragmatically, it's hard to execute in Parkland. I just say, just take, up to 60 milligrams. I don't go over 60 milligrams of prednisone. Okay. And then I feel nervous about going from 60 milligrams of prednisone to 0 on month 2. So I have this brief rapid taper over a week. So in my month version of modified Ponticelli protocol, some of them protocol, we will have in month 2, there's a 1-week overlap of steroids tapering when you start your cyclophosphamide. Okay. Yeah, in month 4 as well, and month 6. Yeah, there's a period where about a week you're taking this really rapidly tapering prednisone dose while you're starting your cyclophosphamide. Okay. Maybe I'm being too paternalistic. Maybe you have the courage to just stop cold turkey. I've just been nervous about that. All right. Mycophenolate is not a bona fide treatment. People try it, but remember I've sort of said in multiple conversations that really mycophenolate should be reserved for lupus, even though it's liberalized because nephrologists are comfortable prescribing it. It's liberalized across multiple GNs. And then there's some small studies that suggest prolonged oral cyclophosphamide as opposed to the modified Ponticelli protocol, might be of benefit. Transplantation, things to know are there is a not rare instance of recurrent disease from membranous nephropathy. Some people have even sort of measured PLA2 receptor antibodies pre-transplant just to make sure the risk of relapse is less. But there is a relapse rate that is not insignificant that occurs. But generally speaking, these are still treatable and don't typically result in loss of the allograft, as recurrent FSGS is. Recurrent FSGS is really very traumatic outcome in a patient who's undergone transplantation. But recurrent membranous is typically a manageable. You're not back functionally on dialysis when you're getting plasmapheresed in the FSGS recurrence, which obviously is a really hard hit for a patient to undergo. Okay. Now, de novo membranous is a fairly common GN that you'll see in the post-transplant patient. So post-transplant GN, the most common post-transplant GN, except for disease recurrence, is membranous nephropathy. Okay. And the way you can think about that is, you have these alloantigens that are presented. And so one form of allo recognition might be the development of a membranous nephropathy. And to push that analogy further, the most common, cause of proteinuria absent, underlying diabetic nephropathy in a BMT patient is membranous nephropathy. So that's a form of graft versus host disease. BMT patients, when they develop proteinuria, when it's not diabetes, or related to their mTOR inhibitor for GVHD, it's membranous nephropathy most commonly. Okay, so think of that as a form of allo incompatibility. Okay, either because you've had a bone marrow transplant or because you've had a renal transplant. Okay, everybody get that?
Does that affect your decision, like PNI versus like the Oxima, because the patient is already in the calcineurin inhibitor,
Yeah, so the question is, if I develop de novo membranous in a transplant patient who is on belatacept and not a calcineurin inhibitor, I'd put them on a calcineurin inhibitor. If they were on a calcineurin inhibitor already and they're mycophenolate, I would be probably treating with a rituximab infusion, right? It would be a stretch for me to say, let's start going modified Ponticelli in a post-transplant patient. Not impossible, but would be a stretch. Okay, it would certainly be, let's start with rituximab. Or again, if you're on belatacept, I would put you on a calcineurin inhibitor. All right. A word about anticoagulation in nephrotic syndrome. This can translate into other GNs, but is intentionally placed in the membranous nephropathy chapter because the risk of thrombotic event is most with the idiopathic nephrotic syndromes, and even secondary nephrotic syndromes, is most with membranous nephropathy. Okay, so I really rarely, I can't even think of a patient off the top of my head where I've used full dose anticoagulation proactively to prevent a thrombosis in the patient. Okay. But it's not unreasonable to think about. Okay. We even had a patient actually as their presenting feature of their membranous nephropathy, we think of DVTs or venous thrombophilia or thrombotic events, but I have a patient who had acute arterial thrombosis of their arm as a presenting feature of their membranous nephropathy. Had to have it filleted open and acute thrombectomy. He didn't have edema. He presented with an acute vascular insufficiency of his arm. So the arterial events can occur. Interestingly, renal vein thrombosis is another unique way that nephrotic syndrome can present. So they can have the typical, femoral DVT, but many of these patients actually have renal vein thrombosis. Okay, and you can see that reasonably commonly when you have heavy proteinuria. Okay, especially with membranous nephropathy, and that can present with no symptoms. When it's acute, it can present with hematuria and pain, and might require CT angiography in order to diagnose this. Again, thrombotic events in the setting of nephrotic syndrome is most commonly occurs with membranous. Other risk factors include proteinuria greater than 10 grams and serum albumin that's less than about 2 grams per deciliter. Okay. And then, of course, if you have previous other, risk factors, previous thromboembolism, hospitalized with a hip fracture, and those would also be additive in terms of risk for thrombotic events. There's a calculator online, so if you look, at UNC nephrotic syndrome, thrombotic risk. You can get to a UNC, that's University of North Carolina, Chapel Hill, risk calculator to plug in, diagnosis, proteinuria, and serum albumin. That's essentially what goes into the calculator. So to me, it's really just fairly straightforward to just say, well, if I have a membranous patient with an albumin that's in the ones, that's when I would be considering anticoagulation. Okay, in large part, I'm just getting them on treatment pretty early, and I'm sometimes putting them on aspirin to make me feel good. There's a weak data in support for antiplatelet agents for reducing thrombotic events, but I just kind of jump on these with my immunosuppression, or my antiproteinuric interventions are successful in lifting the proteinuria or the albumin out of the dumps, and I get it over 2. Okay. All right. Questions before moving briefly into IgA nephropathy? The question is, if I have ESRD and I'm making urine, what would I do with my anticoagulation? That is a interesting hypothetical. I would say that, by the time you're ESRD, your proteinuria is starting to tail off as well, right? Because proteinuria requires glomerular filtration in order to manifest, right? And so as your glomerular filtration is, down to less than 10, generally speaking, your proteinuria is starting to fade as well. Okay.
Are DOACs acceptable for anticoagulation?
Presumably, yes. Yeah. It's not like, for instance, antiphospholipid antibody syndrome, where there is a, it's really warfarin as the go-to, and you're kind of going off label when you're using DOACs.